Hi everybody. We're going to spend a little time talking about pediatric nutrition and growth. Dr. Kopak has already talked to you about failure to thrive in older adults. So we're going to talk about the corollary in children. Children are very dependent on us to provide their nutrition for them, so that we as providers spend a lot of time supervising that feeding of young children. It's an important indicator. We monitor growth as an important indicator of how well children are doing from a whole range of aspects. One is it gives us important clues about the general physical condition. Are they healthy? Do they have any disease processes going on? Also tells us a lot about how they're being cared for. It also gives parents important feedback on the fact that they're doing a good job of parenting. So they're usually very anxious to be sure that their child is growing properly. When children don't grow properly, then there are lots of concerns that we have. So let's get started. First, a review of newborn infant nutrition. Full-term infants require 110 to 120 calories per kilogram per day, and normal infant formulas and breast milk supply about 20 calories per ounce. Formulas with higher concentrations are available. For example, preemie formulas routinely have 24 calories per ounce, but most of the standard formulas and breast milk will be 20. Infants may lose up to 10% of their birth weight under normal conditions, but we do expect that they would regain that by 2 weeks of age. So with this in mind, we usually start calculating weight gain at about 2 weeks of age. In other words, the weeks from 2 weeks forward, because by then they should have regained their birth weight, and we can start figuring out if they're gaining properly from there. Infants should be fed breast milk or formula exclusively until at least 4 months and preferably 6 months of age. It's a guideline from the American Academy of Pediatrics. Why? Well, first of all, babies have the necessary oral development by about 4 to 6 months to move food from the front of their mouth to the back. In other words, they've gone beyond sucking as their only mouthing ability. So if you're introducing things much earlier than that, you get it all back when you try to feed it to babies, as they still have a lot of tongue thrust. Also, babies need a lot of protein in that first 6 months, and milk is really a good source of that. And why do they need so much protein? Because they're growing so fast. Starting about 6 months of age, though, they need an iron source in their diet. And they need it because full-term babies come with iron stores in their liver that'll last them till about 6 months of age. Milk is not a particularly good source of iron. Breast milk is also not a good source of iron, but the iron that is in breast milk is absorbed a little better than it is from cow's milk formula. But neither of them are really adequate after 6 months of age, so you need to get that iron source in there. You usually introduce solids from least allergenic to most allergenic. Now, if a child has a strong family history of allergy, then you want to be avoiding cow's milk, knowing that standard baby formulas are cow's milk, Similac and Famil. But in a baby with a family history of allergy, you generally would really want to encourage breastfeeding or perhaps use an alternate formula. So if they have that strong family history, you want to avoid cow's milk and wheat and egg whites. But in most kids, even so, we try not to introduce that wheat right away and the egg whites right away. The other factor here is that the small bowel is much more permeable to foreign proteins in infants than it is as they get older, which means the potential for establishing allergy is greater. Those foreign proteins can get through the small bowel wall easier in infants. So it's another good reason to kind of postpone those allergenic foods until a little later in the first year. The order of introduction of foods actually can vary quite a bit. The standard for quite a few years has been iron-fortified rice cereal, but you do understand that we didn't always have iron-fortified rice cereal. If you looked at 40 years ago, it was pretty common to start babies on some sort of strained meat at the beginning, and the reason was they needed an iron source. Another good source of iron is egg yolks, not the egg whites. They have a lot of foreign protein in them, but egg yolks. If you hard-boil the egg and take the yolk out and mash it up, it's a really good source of iron. So what you introduce first should be low on the allergenic scale, and it should be easy to digest, and it should be a source of iron. And those are kind of your guidelines on what you introduce. So usually start off with 1 feeding per day, a tablespoon or so. If you're going to start with rice cereal, then it's nice and bland, so most babies don't object to it too much. Doesn't have a lot of flavor to it. If you've tasted it, you know that. You start off with maybe a tablespoon or so of it, with some formula, some breast milk, or even some water in it is fine. And you start that at 1 feeding per day, and then gradually increase to 2 and then 3 feedings per day. Most people do 1 in the morning and then add 1 in the evening and then 1 in the middle of the day, but babies sometimes give you different feedback on this. I have a grandson who's just started on solid foods, and my daughter tried first some cereal in the morning, and then she tried to add some in the evening, and he was just too tired late in the day to be tolerant of taking solid foods and trying new things. So she went to introducing it morning and then after, and then basically lunchtime. And they'll try the evening feeding a little bit later when he's gotten a little more used to it. When you start babies on solids at 6 months, you start with pureed or ground foods, but you can graduate pretty quickly to soft table foods, so that you don't have to keep them on those baby foods for very long. And commercial baby foods are expensive, and you can also, of course, make your own baby foods, and with a little baby food grinder or a blender, and you can teach parents to do that as well. Infant growth. Normal weight gain is a ½ an ounce to an ounce a day for the first few months, normally closer to an ounce per day during the first couple months, and then slows down. Remember, you sort of calculate that from about 2 weeks on, or whenever you're sure they're back to their birth weight if you've been weighing them in the office more often. Babies should double their birth weight by 5 months, triple by a year. In terms of teeth, the first teeth, the lower central incisors, can appear any time between 6 months and a year. And this often kind of runs in families, so that you'll see some families where kids get their teeth late and some where they get them early. For breastfeeding moms, they're always glad if they're getting them a little bit later, usually. Toddler and preschool growth. Most kids in this age category gain 2 to 3 kilograms a year, grow 6 to 12 centimeters. Some people say you can double a 2-year-old height for an adult, but it doesn't work all that well. It's really different for boys and for girls. And it works well at the extremes. So the child who's really tall is probably going to be a tall adult, and a child who's really short probably going to be a shorter adult, but in between it's not a terribly accurate predictor. Most kids should have about 20 deciduous teeth by about 2 years, sometimes a little bit later. They start with those lower central incisors and then the lateral incisors, and then the teeth work their way back to the first year molar, which comes in about a year or shortly thereafter, and then the second year molar. And that whole thing is delayed depending on when that whole process starts. Oftentimes parents think babies are teething early on, about 4 months, but it's also a time when the salivary glands are developing too, so they sometimes drool a lot because their salivary glands are developing and not necessarily because they're teething. Appetite decreases sometime in the second year. It's called physiologic anorexia. It's often a source of worry for parents. You want to emphasize always to parents, we'll talk more about this, but feed only good nutrient sources. When kids don't eat well, you want to be sure that whatever they get is a good source of nutrition. And I just remind you that excessive weight among American children is thought to be related to decreased exercise as well as increased calories, so you want to be paying attention to both of those. I put in a reminder about calculating fluid requirements. It's not really related to failure to thrive, but I just wanted it as a reminder to you. If you don't remember how to do this from FNP 1, then go back and review it. This is the same slide I had then, because you need this to know, particularly in children who have vomiting and diarrhea, how much fluid they require in a 24-hour period. Can generally tell you whether children are getting enough fluids as well, if you have some question about it for some other reason. Caloric requirements for children, I already said 110 to 120 for young infants. For young children, you can generally calculate at about 100 calories per kilogram per day. This turns out to be about equal to their fluid requirements if you have calculated those. Some important nutrients to consider. Iron, the RDA in young children is 10 milligrams a day. You should check the H&H at the end of the first year. Why? Because the iron stores, remember, ran out at 6 months, and anemia is most common towards the end of the first year. This usually indicates the child's not getting adequate iron source in their diet, and that's why you want to check it at that point. If it's low, you'll need to recheck it, or if their diet indicates or they have some sort of symptoms. The most common cause of inadequate iron at this age is excessive milk. Remember, milk's not a great source of iron, so if they're getting too much milk, then they're not getting enough iron. Calcium, the RDA is about 800 milligrams a day. 8 ounces has 300. 8 ounces of milk has 300 milligrams of calcium in it. So if you get 22 to 24 ounces of milk a day, you've got more than enough calcium in your diet. Soy milk these days is supplemented to that same level, as is calcium fortified orange juice, so you have a lot of choices about where you can get it. Inadequate calcium usually only a problem in children who can't tolerate dairy, and even then, if you give them a soy milk product, the soy milks are generally fortified. Children need a fluoride source for purposes of developing good dentition. The RDA is about 0.25 milligrams per day in young children, works its way up to a half a milligram, and then by about 12 years of age it's up to 1 milligram a day. It's met if the water is fluoridated to 0.6 parts per million, which is the most common fluoridation level for municipal water supplies. There are few municipal areas that will fluoridate to only 0.3, and some that don't fluoridate their water still. Not common, but does happen. You do want to inquire about the water source. If they have well water, it wouldn't be fluoridated unless it's naturally fluoridated, and they'd have to have a water analysis. People with a well should have that done about once a year anyway. And if they're using bottled water, most of the bottled water is not fluoridated. You can buy fluoridated water in the infant food section, but it's very pricey. If they're going to use bottled water, then I would suggest you just provide a supplement in terms of a prescription, which will be a lot less costly for them. If they don't have access to fluoridated water, then you need to supplement between 6 months and 12 years of age. And here's the forms that it comes in. Tablets, chewable, comes in 0.25, 0.5, and 1. Drops, 0.5 milligrams per milliliter. And so those would be fluoride drops on their own, and then multivitamin drops, where you can get a multivitamin, either tribifluor or multifluor drops, where you have a multiple vitamin combination with fluoride in it. All are prescriptions, so you have to provide that for the family. Obtaining a nutritional history, of giving some links for some sample dietary screening tools for infants and children. Don't forget to ask important questions like where does the child eat and with whom, who prepares the child's food, what kind of feeding assistance do they get, and is it appropriate for their age, and how many meals per week are eaten out. If the child's in daycare, be sure that the parents know what the child is eating in daycare. The basic tools are there. You get a 24-hour dietary recall and then a food diary if you need one. Assessing growth. You need adequate records, so the child should be weighed and measured on every visit, and you want, of course, be comparing that to norms. You want to be using the standard growth charts. So we looked at these growth charts before in terms of determining when should you worry about a growth chart. You should worry about a growth chart when a child is very low on the growth chart, very high on the growth chart, not proportional between the weight and the height. So you've got a child who's very high on the weight end and low on the growth, on the linear growth side, or vice versa. Or when a child has an abnormal pattern, as we're starting to see here. So here you see a child who is falling off the growth chart, doing well here, and gradually losing ground on the growth chart. You see the typical pattern when a child is losing ground is they lose ground on weight first and then height. And this child, you want to find out what's going on with them, that this is happening. You want a really thorough history. This child, on the other hand, you might initially be concerned about because they're low on the growth chart, down around the 25th percentile here, or even the 10th, looks more like the 10th percentile, isn't it? 5th to 10th percentile. But first of all, they have a very steady pattern. They're proportional between both height and weight. This is the family where you want to start asking the questions and looking at the family. This child perhaps is going to be small in stature. The family may be small in stature. The family may have a growth pattern where kids tend to do their growing a little later on. So certainly you want to be getting a good history here, but this child may actually be okay. Using BMI in children, a reminder that adult BMI numbers cannot be used in children because the ideal BMI varies with age in children. So you want to use the CDC child charts. So if we go have a look at those, the child and teen BMI calculator, you see that you've got to put in the birth date and then the date of the measurement, so you have an adequate age, the sex, the height, and then the weight. So you're using more than just height and weight to calculate this. You're using age and sex as well to calculate the BMI. So be sure that you use a child indicator. See if we can get back to our slides here. Okay, so what factors affect normal growth? Genetics, obviously. Is the family small? Are they large? Are they slender? Are they heavier? What's their body build? Feeding patterns. Remember, the family feeding patterns are going to be passed on to the child. So you want to know what those feeding patterns are. And you want to find out what they are because they're being passed on to that child. And try to intervene not just in the feeding pattern for the child, but in the feeding pattern for the whole family. Of course, it's influenced by the content and appropriateness of the diet, the amount of nurturing by the family, and any pathological physical processes that are going on. What is failure to thrive? A persistent lack of physical growth and often development as well, without an obvious cause. It's your job to figure out what the cause is. So what are the causes? What I should have on this list is lack of education at the top. And I don't know why I didn't put it on here. But that should be the first thing that you begin to investigate. Is this a family that knows how to feed a child? Do they know what children need at various ages? Are they feeding the child appropriately? Need to distinguish that from inattention, where the child just isn't being attended to in terms of adequate feeding. The family's large, the parents are working, the child's in daycare, you don't know what kind of feeding the child's getting in daycare. Could be a whole variety of things. Is the child generally neglected? What's their hygiene like? Are they brought in to see the primary care provider when they're ill? Do they make their regular appointments Have they been on their regular immunization schedule? All indicators that the family is attending to the child's well-being. Failure to attach. John Bowlby and others in the 50s showed very clearly that babies who have not attached to a significant person don't grow well. Showed this very clearly in orphanages where children were fed regularly but didn't grow well until they assigned them to a primary provider in terms of someone who did their caretaking on a regular basis, held them on a regular basis, and then these babies would grow. And of course, disease is another consideration. What are the organic causes? These are sort of the big three here. Some sort of malabsorption, and the two most common reasons for that would be cystic fibrosis or celiac disease. So those are things you need to be thinking about. Chronic kidney disease and then HIV. So if you remember this sort of as the big three, these are the things you probably want to test for up front. Non-organic, the neglect things, the failure to attach is usually seen in very young children. Assessment of the slow-growing baby or child. What do you want to do? Assess nutritional intake with a careful history and a food diary. Assess the family eating patterns. Who feeds? Where? What do they eat? How often do they eat out? All of that. Observe and record the parent and child interaction. Get a developmental history. Is the child developing appropriately? Look for signs of neglect. We talked about that. Hygiene. Those other things. Get a history of a stool pattern. Remember, you're looking for CF or celiac. And do a very thorough review of systems to look for other potential causes. This is where your review of systems can really be helpful to you. Physical exam. Assess the growth pattern. We talked about that. Calculate the BMI. Assess their development. Look at skin turgor, skin and hair quality. Why? Because these are often indicators of nutrition. They're sometimes late indicators, but they're indicators. Think about the extremes here. When I was in Africa, I would see kids with kwashiorkor, protein malnutrition, who were African, black, and whose hair was blonde. It's because they couldn't produce adequate melatonin because they were so protein malnourished. So that's the extreme, but you do look at skin and hair quality. Subcutaneous tissue and fat, muscle tissue. Diagnostic tests you want to consider. A UA, remember kidney problems. A serum protein, what does that tell you? It tells you whether the child has adequate protein in their diet. A CBC, this is going to be your best indicator of iron, B12, or folate in their diet. You can order those levels, the iron indices and then B12 folate levels. But I'd wait until after you get the CBC. If the CBC is normal, probably isn't any reason to order them. A stool analysis, particularly looking for fat in the stool, which would indicate malabsorption. Be sure that you know their HIV status and perhaps order a sweat test for them for CF. Management. I really should put family education at the top here, but we'll discuss a little more about what kinds of things you commonly have to educate about. But if you think that they just need to know more about how to feed the child, then obviously you start with that in terms of your management. You want to follow up in short order to follow their growth, regardless of what intervention you are using. And they may need repeated visits and pretty often to make sure the child is growing normally. Consider flagging appointments so that the family can't cancel without you being aware of it or someone following up with them. Some offices, depending on what kind of an appointment system you can use, you can put in some sort of a flag for this. I cannot cancel. If they cancel, somebody gets notified that they've canceled. So you can follow up and you don't lose them to follow up. Refer to a nutritionist if needed. This may be a child that has some nutritional issues. Might be a child with a gluten intolerance, for example. If you can't find anything with the initial test that you do, then you want to think about gluten antibodies. Appropriate referrals for any diagnoses and Then, of course, we talked about education. Common nutritional issues in children which require educational efforts on your part. Too much milk at the end of the first year. When kids don't make a great transition to solid foods, they're not good eaters. The temptation is to give them their milk that they want, because otherwise parents will tell you they won't eat and they'll starve. Well, the problem is that the milk is suppressing their appetite. So you've got to assure parents that they won't starve, that they need to, if they're thirsty, give them water. They can't have juice, but not too much. Juice is a common problem with kids. You need to limit juice as well. It has some vitamins in it, also has a lot of sugar in it, and will suppress appetite really well. So not too much milk, not too much juice. Don't give solids too early. You might need to educate about that. We've talked about why. This is an area where you may need some education. Don't give too much fast food or too much fat, and that usually is related, those two, too much fat, too much fast food. Family meal time is important. Families that eat together, children generally have better nutritional patterns. You can encourage family meal time. And picky eaters. What to do about picky eaters. You often spend a lot of time talking to families about that. Not too much milk, not too much juice. Give them only nutritional foods. Don't waste those calories on junk foods. Make sure that they're eating. Even if they're eating, they're highly selective in what they eat. If they're only getting nutritional foods, they'll generally do fine. And you know how picky eaters are. It's only yellow foods this week, or it's only dairy products, or it's only who knows what, bread and peanut butter. But as long as it's nutritious, they'll generally do okay. And that's basically our guidelines on pediatric nutrition and thinking about the causes of failure to thrive and the fact that sometimes children don't grow the way you want, and an important part of our job then is to find out why it is they aren't growing well.